Hi, everyone. Thank you for joining us. We opened up the webinar a few minutes early so we could make sure everyone got in before we start at 3 o'clock. So we'll be open for about 5 minutes before we'll begin the webinar. Thank you very much for joining us.
Hello?
Thank you, everyone, for joining us. We have about 2 more minutes that we're going to have people come in and join the webinar, and then we will begin promptly at 2 o'clock. Hi, everyone. Thank you so much for joining us today. My name is Nadine Cookson, and here at School-Based Health Alliance, we'd like to thank everyone for attending today's webinar titled The State of the Science, Teen Brain Development and the Impact of Marijuana Use. During today's webinar, we will provide a brief overview of the latest science on what's going on in the brain during the adolescent and emerging adult years, and on the possible effects of marijuana exposure during these years on brain structure, function, health, and social outcomes. But before we begin, we have a few housekeeping reminders. First, please help us with our attendance count. If you're viewing as a group, please go to the chat window in the chat icon and type in the name of the person registered and the total number of additional people in the room. For example, Tammy Jones +3. This will help us with our final attendance count. Also, all attendees are in listen-only mode. However, we want to hear your questions. To ask a question at any point during the webinar, please use the Q&A tool located in your Zoom control bar. We will address questions following the presentation. At the end of this webinar, attendees will be asked to complete an evaluation poll questions. Please let us know how we're doing. Your feedback is vital in helping us craft presentations that meet your needs. The School-Based Health Alliance works to improve the health of children and youth by advancing and advocating for school-based health care. We believe that all children and adolescents deserve to thrive, but too many struggle because they lack access to healthcare services. School-based healthcare is the solution, bringing healthcare to where students already spend the majority of their time, in school. When health and education come together, great things happen. Attendance improves, conditions like asthma or diabetes are better managed, behavioral health issues get quick expert attention, and we all know that healthy students make better learners. This webinar is being recorded and will be archived on our website in 3 to 5 business days. Please also visit School-Based Health Alliance for additional archived webinars for topics such as the ones you are viewing on your screen. Now I would like to introduce our presenter today. Dr. Seon Kim Harris is an associate professor of pediatrics at Harvard Medical School and faculty in the divisions of adolescent, young adult medicine, and developmental medicine at Boston Children's Hospital. She is the director of the Center for Adolescent Substance Abuse Research, an international research center focused on the development of innovative, effective strategies to prevent, diagnose, and treat substance abuse in youth. Dr. Harris published the first large multi-site trial of primary care-based screening and clinician brief advice to address adolescent substance use, and has published nearly 70 original scientific publications and has received numerous awards, including the Young Professional Award from the Maternal and Child Health section of the American Public Health Association, the T. Barry Brazelton Innovation Award, and the T. Barry Brazelton Innovation Award. She received her doctorate from the Johns Hopkins Bloomberg School of Public Health. Thank you, everyone. I will now turn it over to our presenter.
Okay, thank you so much. And I'm going to share my screen now. Okay, so good afternoon or morning or whichever time zone you're in. It's my pleasure to talk about teen brain development and the impact of marijuana use today. It is a very timely and hot topic because of this phenomenon, which we're all well aware. I call this the other greening of America. And this is the latest map of state marijuana policies across the country. We now have 46 states that have legalized marijuana in some form. Specifically, 31 have legalized medical marijuana or recreational marijuana use. 15 have legalized use of only low THC and high CBD, CBD referring to cannabidiol, which is one of the components in the cannabis plant. So this kind of marijuana is the only allowed marijuana to be used in those 15 states. And we are still at the federal level having marijuana as a Schedule I drug, which means that there are no approved medical uses and high potential for abuse, which essentially means that it is not allowed. So this is where we are today. And so we have this rather challenging situation of what our young people, our adolescents, are now seeing relative to marijuana. So these are images that they see today, that it is medicine, and then there's lots of marketing now that marijuana has been commercialized, and these are just some of the ads that are available on social media and the web that are showing that marijuana is, conveying that marijuana is, say, harmless. It doesn't impact performance, and even marijuana inspires successful Americans since 1776. And then these are the kinds of products that are available in states where recreational marijuana has been legal. And you can see how much these products have been made to look like products that young people are familiar with and love, and implicitly conveying that marijuana is harmless. And I'm going to talk about edibles later in my talk. So that is probably, so those images and that greening of America relative to marijuana legalization is probably what's underlying the trend in adolescents' perceived risk of harm of marijuana. And this chart you may have seen. This is from the National Monitoring the Future Survey, which is done every year and has been for 30 years. This is the latest, so from 1975 to 2017. This is among 12th graders that were surveyed. The yellow line is the percent that perceived a great risk of harm from regular marijuana use. And then the red line is the percent reporting having used marijuana in the past month. And what's amazing about this graph is just this mirror-like relationship between perception of risk of harm and past month use. And so, the higher the risk of harm, the lower the use. And then we've seen this real strong drop-off in that perceived risk of harm. And we are now at a historic low in terms of the percent of 12th graders who think that marijuana use has a great risk of harm. So I just wanted to give you some context about where we are with adolescent substance use today. Again, from the National Monitoring the Future Survey, these are the trends in US 12th graders reporting having used each substance in the past month. And these are data from 2000 to 2017. And so what you see here is really encouraging trends in for alcohol and tobacco use, strong declines that we've seen in the last almost 2 decades, and also even a decline in illicit drug use other than marijuana. But here's where we are with marijuana use and vaping, which is related to marijuana use, as well as to nicotine use. But as you can see, marijuana trend is kind of an anomaly in that it was starting to decline in the 2000s, as with alcohol and tobacco, but it has now kind of reversed that trend, and we're sort of inching up in that in the recent years. And then, of course, with vaping, we've seen a remarkable rise in that use among adolescents. And just FYI, Colorado allowed a commercial marijuana industry in 2009, and that seems to coincide with when the trend in marijuana really kind of started, going up, and also when marijuana and tobacco use basically flipped in terms of prevalence. That marijuana is now more common among adolescents than tobacco, cigarette smoking, but not relative to, say, e-cig use. In terms of more heavy substance use, this chart shows the rate of binge drinking in the past 2 weeks, daily cigarette smoking, daily marijuana use, and daily alcohol use, and among 12th graders again. And as you see, we're also making good progress around the heavy alcohol use, the binge drinking. That's seen a decline of almost by half. A tremendous decline in daily cigarette smoking, but we have not made any progress at all around the daily marijuana use, and this is probably going to continue to go up. And daily alcohol use is pretty non-existent among adolescents. I mean, that's not something that we see in the younger ages, maybe in the adult ages. But I want to point out the difference between the percent of 12th graders who report daily marijuana use, 6% in 2017, compared to daily alcohol use, only 1%, because that is an indicator of how addictive marijuana use is relative to, or in terms of the pattern of use among young people, compared to alcohol use. And because there's, of course, the claim that marijuana isn't addictive, but in terms of the percent that are using daily, that is much higher than those who are using alcohol daily. And this is a chart from the latest National Survey on Drug Use and Health. It's a household survey of individuals ages 12 and up. And this data is for ages 12 to 17, and this is showing across every state, all 50 states, the percent that reported using marijuana in the past month. And I highlighted in red states with any legalized marijuana during the years 2014, 2015. And you can see how there's this pattern of those states with legalized marijuana having the higher rates of adolescent use of marijuana. The top 3 states in the latest data in 2015 are Colorado, not surprisingly, Vermont, and Rhode Island. So we may be, all of us, struggling with this question from a lot of people out there who say, well, so what? And these are often the marijuana myths underlying that so what, that it's not addictive and it's harmless and natural. So let me address these questions one at a time. And let's look at the science. So first, is marijuana addictive? Well, scientists have, over time, found a pretty easy way of studying the addictiveness of drugs. Using animal models. And essentially, you use animals where you allow them to self-administer a substance and see if they spontaneously start to repeatedly administer the substance to themselves. And that is exactly what they found with marijuana. Just as they found that with opioids and alcohol and cocaine, they found the same thing with marijuana. And when you look at the neurobiology, there's a part of the brain that you may have heard of, the reward pathway. And this chart shows the different parts of the brain that are involved in this reward circuitry, which gets activated when there's when we're doing things that give us pleasure and give us positive reinforcement and make us want to do things over and over again. And this is the part of the brain that has the release of dopamine. You might have heard of dopamine as a chemical that is involved in pleasure, among others. But so this reward pathway is and this part of the brain is called the striatum, which is right in the center here. This reward pathway is activated by every single addictive substance, alcohol, heroin, etc. These are all sort of counterfeit highs that activate this pathway in the brain through sort of artificial methods and cause a strong response in this part of the brain. And marijuana is no exception compared to these other substances, as shown by the science. That THC, which is the main psychoactive chemical in marijuana, does indeed induce that dopamine release in the reward pathway, just like the other substances that are addictive. Now, marijuana is especially addictive for teens. To illustrate, this chart shows the percent of substance abuse treatment admissions by substance that is the primary substance being used at the time of admission. This is data for ages 12 to 19-year-olds, and this was from the National Treatment Episode data set from SAMHSA. And so you can see here the percentages that are due to alcohol, heroin, opiates, cocaine, methamphetamine, all substances that no one would argue are highly addictive. Here's the percentage that are related to marijuana. Among adolescents, marijuana accounts for more treatment admissions than all other substances combined. So if it's not addictive, how is it that we have the majority of young people who are engaged in substance abuse treatment being admitted for marijuana as the primary substance of dependence? Now, is marijuana harmless? Not for the teen brain. So let me unpack that for you. So as we at this point have heard, what we now know is that adolescence is a sensitive period in brain development, and that the brain is still developing until the mid-20s. And I want to focus on these two words in particular, sensitive period, and define that for you because they have a particular meaning in neuroscience. So sensitive period or critical period, kind of similarly used, refers to a window in brain development when a part of the brain is developing rapidly and is highly sensitive to being shaped by environmental exposures and experiences. And we now know that adolescence is a sensitive or critical period in brain development, and actually is the last major critical period in brain development. And so, yes, brain development, we now know, is this interaction between your genes and the experiences that you have, and that those interact to create the brain that we now have. So for example, when you have identical twins, they're born with the same DNA, but as they grow, they encounter different experiences, different exposures, and you end up with distinct personalities, even among identical twins. So I want to kind of unpack for you what exactly we mean by brain development during adolescence. And I'm going to highlight two key brain developmental processes that are going on into the mid-20s. Pruning and myelination. So to explain what those mean, I need to give you a quick lesson in neuroscience. So this is an actual picture of neurons in the brain. And you can see the main cell body and then all the spindly arms that reach out. So these are actual neurons that are seen under an electron microscope. And the basic structure of the neuron is that at the top you've got the cell body with the nucleus that has the DNA, and kind of these spiky projections called dendrites, kind of like a punk rocker's hair. And then you have, there's the cell body, and then you have the long spindly arms that reach out. We call those the axons. And the neuron communicates one neuron to another in the brain through electrical signaling, which activates the synapse, which is the connection between one neuron and the next neuron, to send signals to have different parts of the brain communicate with each other. And this is really important because I'm going to be talking about how THC and cannabinoids work in the brain. Now, so up until about age 12, the brain is growing, and there's a rapid growth of neurons in the brain. But around age 12, the brain cells and the connections between brain cells start to undergo pruning. And this is governed by something called the use it or lose it principle. That is, the connections that are used a lot get kept and strengthened in the brain, but that the connections that are not used get pruned away. So it's a sculpting process in this pruning process. And so just to illustrate, at birth, we don't have as many neurons as we're going to get, ultimately. And then there's a rapid proliferation of these brain cells and the connections between brain cells during early childhood. And then in adolescence, we start to see this pruning process. Now, while this pruning is happening, at the same time, myelin starts to cover the arms, those axons, and thicken. So this picture shows this fatty white tissue kind of wrapping the axons of the neuron. And that fatty white tissue functions like insulation on an electrical wire. And that helps neuron signals to travel 100 times faster. So that, the speed at which different parts of the brain are able to communicate with each other and pass signal greatly increases. So these myelinated axons, the turning of brain cells from kind of gray unmyelinated neurons to white matter, what we call white matter, those are myelinated neurons. We call those the white matter tracks in the brain, or the brain's information superhighway. So this on the left side is an actual person's brain scan where the neuroscientists were able to kind of strip the parts of the brain to be able to really show you the white matter tracks. And so you see these long spindly fibers, those are the axons of different neurons. And they are covered, with the white matter. And so you see these fibers that are connecting the front of the brain, the back of the brain, and the hemispheres. And that's, the highway on which brain signals pass. And the result when pruning and myelination are complete are faster but fewer connections in the brain. And why does the brain do this? So this, just to show you what the brain, and we call these white matter tracks the brain's connectome. So these are images from brain scans showing these the fiber tracks. And we are now finding out in the latest brain science how critical the brain's connectome, or the wiring of the brain, is to healthy brain function. That there are lots of disorders of the brain like epilepsy and even autism, schizophrenia, that are a lot of what causes those disorders is miswiring of the brain. Now, we now understand that pruning and myelination happen really all through the adolescent years into the mid-20s. So I just want to illustrate for you, this is a compilation of brain scans where they are able to show in different colors the gray matter converting to white matter through adolescence. So just watch. So as you can see, just visually, how dramatic the brain development is during the adolescent years, that we now understand that there is this really important continuing maturation that happens through the adolescent years. And why does this happen in the brain? Well, it's speeding up the commute. That is, you know, if I am trying to get somewhere from point A to point B, I want to take the most direct route, the shortest possible route to get there, and get rid of I want to avoid all the local roads, which would slow me down. And that's because a lot of what we do in terms of behavior, or really anything we do with our brain, that they involve different parts of the brain having to work together. And in particular, some of the higher order kind of executive functions like self-control or emotional regulation or having good judgment, that those activities, excuse me, are governed by a part of the brain called the prefrontal cortex that you may have heard. It's at the front of the brain, and that is the part of the brain that actually takes the longest to fully mature. And in order for that part of the brain to really do its job well, so for example, in terms of self-control or emotional regulation, it needs to be well connected up with the parts of the brain involved in, say, emotion or impulsiveness, and that the prefrontal cortex, to be able to do its job, needs to be, you know, kind of tightly linked with, say, the emotional center of the brain, to be able to, you know, stop us from, say, if we're angry, you know, blurting out something that we're going to later regret. So the wiring up of the prefrontal cortex with the rest of the brain is really critical for that, for the ability, for those abilities to develop appropriately. And that's what's happening during the adolescent and young adult years. So that we can go from this in childhood to being able to do this, which is to control those impulses and maybe think about, you know, is this really good for me at this time for what I want to achieve for myself. Also, it helps increase processing speed and reaction time. So, you know, going from sort of not being very good at, you know, soccer to, you know, those kind of quick reaction time reflexes that young people are able to develop through practice. So we now know that the teen brain is highly neuroplastic, meaning it's highly malleable and is tremendous at learning. But that's a double-edged sword. It's a time of both opportunity and vulnerability. It's a time of great opportunity because adolescence is a great time for getting good at something. So, you know, a time to learn that instrument, a sport, dance, whatever it is that adolescents, you know, get engaged in, putting the time into developing the skills during adolescence, it is much easier to pick up these skills and really strengthen them and get good at them when you start, you know, in childhood and adolescence compared to when the brain has become more set and less malleable or less neuroplastic as an adult. As I said, it's a double-edged sword, so that malleability or neuroplasticity makes the teen brain more vulnerable to the harms of things like alcohol and drugs compared to the adult brain. So let me tell you about the teen brain on marijuana. As you may have heard, in terms of what are the ingredients in marijuana that we consider cannabinoid chemicals, The component of marijuana that we know most about and that is associated with the most psychoactive effects is THC, the delta-9 tetrahydrocannabinol. There's been tremendous interest also in something called cannabidiol, which it turns out has very different effects from THC, and in some cases almost the opposite effect of THC. And then there's a whole bunch of other cannabinoid chemicals that we know less about, but there's a lot of study of those, of all of these chemicals now. So I'm going to focus on THC. So we know that THC crosses the blood-brain barrier and it crosses the placenta, which is really important in terms of pregnant women using marijuana. It's highly absorbed in our fat tissue. And so the more, regularly it's used, the more it gets absorbed, and it takes a long time then to eliminate it out of the body because it gets kind of trapped in the fatty tissue. And THC affects our body and our brain through influencing or sort of binding to the body's cannabinoid receptors that are present both in the central nervous system in the brain and the peripheral nervous system. So the THC has the effects that it has because it binds to receptors throughout our brain. And this picture shows the little pink dots showing where we have a lot of these cannabinoid receptors that THC could bind to. So particularly, on the cortex, in the prefrontal cortex, and then in the middle, remember that reward pathway. Now, why do we have cannabinoid receptors in our brains? Well, so it turns out that our brain's cannabinoid receptors, rather than being designed for THC, they are actually designed for chemicals that our own brains make called, there's two of them. Anandamide is the one of the two that is getting to be better understood. And the THC kind of fools the brain because it has a similar structure, but not exactly the same as anandamide. So what does this endocannabinoid system do in our brain? That is our own brain's cannabinoid system. So remember the basic neuron structure. So I just want to focus right now on the part down at the bottom called the synapse, and that's where two neurons connect to be able to communicate. So this is taking that synapse and blowing it up. And what happens is, so there's the electrical signal coming down from the sending neuron. And sometimes that electrical signal gets too strong. And then what happens is the receiving neuron decides, whoa, that's too strong signaling, and sends our own brain's endocannabinoid chemicals backwards across the little, synapse gap to bind to the cannabinoid receptors that are on the end of the sending neuron. We call that the presynaptic neuron. And when that happens, that tells the sending neuron to kind of calm down. So I call this the neuron's volume control system. So the endocannabinoid system helps to dial down neuron activity and the release of the neurotransmitters, which are the chemical signals that tell that kind of convey the messages from one neuron to another. And it helps to dial those down when they get too strong. And it turns out that this endocannabinoid system is on a lot of different kinds of neurons in the brain. And so it's involved in regulating the levels of many different brain chemicals, including those that affect pleasure, mood, pain, appetite, motivation, memory, growth, and reproductive hormones. So it's got this really diffuse effect on the brain. Now, THC and anandamide do not function the same. Both are involved in dialing down neuron activity to change the release of those neurotransmitters. However, THC has a much stronger, longer effect than anandamide on brain cells, and that THC interferes with our own brain system, that is our own, brain's endocannabinoid system, for protecting neurons and keeping brain activity in balance. So while anandamide works at individual neurons as needed, kind of like a scalpel, THC is like a sledgehammer in terms of this diffuse effect on the brain and in terms of the strength of the effect. Now, repeated THC exposure causes the brain to change. Our brains are constantly learning and adapting, and particularly during adolescence when the brain is more neuroplastic and sensitive to exposures. Repeated THC exposure causes the brain to scale back those cannabinoid receptors because those receptors are being activated, and the brain says that's too much activation and starts to scale back those receptors, causing something called cannabinoid deficiency. That is, we actually have either underactive receptors or we lose receptors altogether because the brain is trying to regulate itself and kind of dampen down something that's being overactive or overstimulated. And that is what underlies what we see as marijuana withdrawal symptoms. So there are absolutely documented marijuana withdrawal symptoms. I call them symptoms of an out of whack brain. And we see restlessness and anxiety, increased irritability, anger, and aggression, difficulty falling and staying asleep, having strange dreams and nightmares, boredom, and decreased appetite. These are symptoms of a brain that has kind of gone, has lost its ability to kind of create homeostasis on itself. And it relies on the THC because it's kind of changed in response to the THC. So when you take the THC away, now the brain is kind of overexcited, and so you see these symptoms. The other thing that's really important to understand about the endocannabinoid system is that it is actively involved in brain developmental processes. We now know that the endocannabinoid system is actually already in the brain and working in the fetal brain, and then continues on to be involved in brain development throughout the life course. So say in the fetal brain, it's been shown to guide neurons to grow to the right places in the brain for correct function. But throughout brain development, it is involved in controlling neuron activity. And during times when the brain is, very neuroplastic, when neuron activity is being dialed down, that's going to affect pruning and brain wiring, because the brain is saying, oh, those connections are not being used very much, so I'm going to just prune those away. And we now also understand that the endocannabinoid system seems to also be involved in myelin growth on neurons. So remember, pruning and myelination are happening throughout adolescence. So those two processes are being affected by, have been shown to be affected by cannabinoids. So if the adolescent brain is regularly exposed to THC, it could alter development of the connectome, the wiring of the brain, which is happening during those years. And we have seen quite a few studies coming out of the brain imaging literature that shows white matter differences in the brains of those who started regular use of marijuana in adolescence versus those who did not. So on the left side, what you see highlighted in the colors are a particular set of white matter tracts called the corpus callosum, and those are the white matter fibers that connect the two hemispheres of the brain, allowing communication between the two hemispheres. And you can see on the left side, those look pretty robust in the non-user, but in the daily user on the right side, you can see that there's less kind of robust white matter there. Now, the question though is, were these differences between these brains present before a person started marijuana use? And perhaps this might have been what kind of increased risk for starting marijuana use or regular marijuana use. So, but what we're seeing in studies that actually followed kids before they started marijuana use and then developed marijuana use or regular marijuana use over time is that in these longitudinal studies, we are seeing confirmation that it is the marijuana use that seems to be producing these longitudinal changes in white matter. So for example, this study and this study. So we're seeing confirmation that these are related to marijuana use. What else is affected by THC in the brain? So this just shows all the different parts of the brain in terms of their different functions. And that is, these are all different things that are affected by THC. And I want to highlight in particular this part of the brain that's got this, that's highlighted in this light blue. And this part of the brain was highlighted in a certain Senate hearing last week. You may have heard of it, the hippocampus. It is the command center for memory formation. And I call it the key to the SATs. And this is really a critical part of the brain, particularly for young people for whom a big part of their job is to learn the things they need, that would set them up well for adulthood. Well, it turns out that THC suppresses the activity of hippocampal cells below the level needed to trigger memory formation. So in order for us to create a memory, those hippocampal cells actually have to be excited and activated to be able to then sort of set a memory in the brain. But THC dampens down the activation of those hippocampal cells. And so that is what, is underlying the very common sort of well-known symptom of having bad short-term memory when you're high on marijuana. Now, with chronic THC exposure during adolescence, neuron connections involved in memory are gradually lost due to continual suppression. So remember that pruning process that happens. So, when those connections are not being activated and strengthened, they get pruned away. So now there's less kind of real estate in the brain involved in learning. And so here's data from a brain imaging study that actually compared the size of the hippocampus between those who were regular marijuana users and those who were non-users, and these were young adults. And as you can see, for those who use marijuana regularly, which are shown in green, their hippocampus size, both on the left side of the brain and the right side of the brain, were on average smaller than those who were not users. So now, I want to highlight the findings of this really important report that came out last year. The National Academies of Sciences, Engineering, and Medicine came out with a very comprehensive report of the research on the health effects of cannabis and cannabinoids, the current state of evidence. This comprehensive review of research was conducted by a 16-member expert panel from all areas of medicine, public health, and social sciences. They reviewed over 10,000 scientific papers published since their last Institute of Medicine review, which was back in 1999, and they brought it all the way up to 2016. And they generated nearly 100 different conclusions about marijuana's effects and risks. And then they rated the strength of scientific evidence for each of those effects or risks. as being either substantial evidence, moderate evidence, limited, or none. And what they concluded was that there was moderate evidence for harmful effects of frequent marijuana use on memory and IQ. And they were drawing on studies like this one. This was a really important study conducted in New Zealand, where they recruited 1,000 young people. And at age 13, when most of these kids had not used marijuana, in fact, nearly all of them had not, they did a comprehensive IQ test. And then they measured, all kinds of substance use indicators. And then they also followed them over the next 25 years doing the same IQ test and measuring substance use. And here's what they found. So at the age of 13, they compared so over those 25 years, they were able to see who started using marijuana versus who did not. And those who had used regularly for 3 or more of those 5 different time points that they were measured in, they looked then back at what their IQ was at age 13 before they started using marijuana, and compared them to those who never started using marijuana during those 25 years. And at age 13, they had exactly the same average IQ, okay? But then by age 38, for those who had started using marijuana regularly and used it for 3 or more years, you could see that there was a significant drop in the IQ, whereas among those who had never used marijuana during those same 25 years, there was no change in IQ. And that same study showed this dose-response relationship between marijuana use, regular marijuana use, and IQ. And regular marijuana use was defined, I think, as weekly use. And here you could see that the longer somebody had used, the bigger the decline in their IQ. And interestingly, there was another study conducted in New Zealand of another 1,000 kids where they followed them from birth to age 25. And they were also able to show a dose-response relationship between the use of cannabis during adolescence and social outcomes at age 25. So whether they graduated from college or university, whether they were employed or unemployed during the young adult years, whether they were receiving welfare. And you can see, again, this dose-response relationship between cannabis use and these outcomes. And now there are studies that show that marijuana-related amotivational syndrome is real. And so that might also be contributing to those disparities in terms of social outcomes at age 25. And I want to just highlight this relationship between marijuana and psychosis. That National Academies of Sciences report said that there was strong, substantial evidence for a link between marijuana and psychotic disorders. And this may be because today we have a very different kind of marijuana plant from what it was 20 years ago, bringing greater risks. So this shows you the trend in the percent THC among cannabis samples that were measured from 1995 to 2014. And, in 1995, we had about 4% THC, and now the average percent is 12%. And it's even higher in, samples of recreational or other kinds of marijuana that's commercially available. But the other thing to note is that the percent of the plant, the typical plant, marijuana plant today, that has cannabidiol, which has antipsychotic properties. THC has been found to have psychotic properties, CBD, antipsychotic properties. The ratio of THC to CBD has really changed. And so now there's a lot more of THC relative to CBD, which might be why we're seeing more of the psychosis kinds of symptoms. The other thing is that there are all these products now that have much higher THC content. And this is, for example, butane hash oil, where the THC is extracted and concentrated through using things like butane. And these products have been shown to contain up to 90% THC. So we're looking at extremely highly potent products that are readily available today. And as THC increases, we see more of the negative effects of THC: paranoia, anxiety and panic, hallucinations, erratic mood swings, aggressive behavior. And we also see, the danger of THC edibles, which also have pretty high potency. And one of the things that's really concerning is that inexperienced users, like young people, who are readily accessing these edibles, don't understand about the time course that marijuana effects have depending on the ingestion method. And here you see that if you take marijuana intravenously or smoked, you get the peak in the high like within the first 30 minutes. But when you eat it, and you see the kind of the more gradual slope, that's the solid line, the peak high is not until 3 hours, or but it varies from person to person. So what we've seen is young people eating, one gummy bear and nothing happens, and then eating another and another, and before you know it, they have completely overdosed and gone psychotic. And things like, and so we're seeing this big rise in emergency room visits caused by marijuana. And the increase in emergency room visits because of marijuana has been particularly high among the younger kids, the 12 to 17-year-olds and the 18 to 20-year-olds. But it's true for a lot of really all age groups. And while people say you can't die from marijuana like you would from opioid overdose, well, we do see people dying from marijuana. So the first death in Colorado after Colorado legalized recreational marijuana and started their recreational marijuana market was this young man, a 19-year-old college student on spring break, who came to Colorado with his friends, bought a pot cookie. The recommended dose was a sixth of the cookie. He ate the whole cookie because nothing happened after eating a sixth, and then went psychotic and jumped out of the fourth floor window of his hotel and to his death. And I would say that in a country where there's more pot and more guns, this is a lethal combination. This is another young man who was a fatality of marijuana. He was in Colorado with his family, and he fatally shot himself after eating 5 marijuana candies and went psychotic. So people can absolutely die from marijuana. And of course, not everybody, go psychotic with marijuana. And it turns out there are specific genes that we now know about that greatly increase the risk of developing psychosis if you use cannabis regularly. And so, for example, this particular gene variant, AKT1, if people have that particular variant and they use daily, that increases their odds of developing psychosis 7 times compared to no use. And so, if a young person has any family history of mental illness, they have to know that they're playing Russian roulette if they're using marijuana. Other things that teens say, well, my parents smoked pot when they were growing up, so why shouldn't I? So, some useful responses to that, because today's pot is much different from, 20 years ago. It's much more potent and dangerous. And we now know so much more today about the harms for teens. For example, we've learned so much more about the harms of tobacco, of trans fats, of concussions, and we've changed our behavior because we've learned about the harms. So, to wrap up, take-home points based on the latest science. Adolescence and emerging adulthood is a time of critical brain development. Repeated exposure to marijuana has been shown to have lasting effects on cognitive functions, for example, memory and IQ, brain structure and function. Today's marijuana is a lot more potent, so it's more addictive and carries more risks to physical and mental health. Marijuana increases the risk for car crashes, and that the risk of psychotic disorders is greater for those starting use in adolescence, especially for those with family risk. So the message to convey is wait. Just wait. Delay use until you've, at least until 21 or older, to give your brain the best chance to mature to be the best brain that it can be. Just as young people wouldn't necessarily want something to engage in something that would impede their physical growth. Hopefully they might feel that they really want to give their brains the best chance it has to grow to be the best brain that they can have. So with that, I give you some recent research reviews that you can turn to for more information, and I'm happy to take questions. Thank you.
Thank you so much. And now this is going to give you guys the time to answer or ask any questions to Dr. Harris that you have pertaining to her presentation. While I give everyone an opportunity to answer questions, we do have a few announcements. The School-Based Health Alliance seeks experts to present at the 2019 National School-Based Healthcare Convention and Rally in Washington, D.C. We're looking for bold and innovative ideas in a variety of school health topics, primary care clinical skills, accounting and quality improvement, population health and education outcomes, business and systems, oral health, systematically targeted groups, advocacy and policy, and youth development. Share your experience, evidence-based practices, resources, and tools with your colleagues from the school-based healthcare field. The call for abstracts is only open until November 6th, so don't delay. Let me tell you a little bit about our membership. The School-Based Health Alliance works to improve the health status of children and youth by advancing and advocating for school-based healthcare. Our members extend and support our work. Trainings like this webinar would not be possible without the support of our members. In addition, our members receive exclusive access to valuable program tools, timely publications, and networking opportunities. Please take a moment after the presentation to visit www.sbh4all.org/membership for more information and to join. So if you guys have any additional questions, please feel free to put them in the Q&A box. So we have one question. It says, over time, it seems like there's a steady level of psychoactive substance use by teens, whether alcohol, pills, marijuana, or other substances. It seems like a game of whack-a-mole, where kids want to try substances and the particular one changes over time. Do you agree? And if so, do you have any suggestions for harm reduction if kids are bound and determined to do something?
So can you hear me?
Yes.
Okay, great. Yeah, I would agree that it is a little bit like whack-a-mole. Certainly, I've been doing this kind of research for 20 years, and just as I was getting comfortable about, how we were doing with tobacco, along comes e-cigs and nicotine addiction in a whole new way, and so it does feel like whack-a-mole at times. But I mean, overall, if you recall the initial slides that I showed on the percent of use of different substances, we have seen really an overall decline in use of substances, and so we are. And there have been, a bunch of news stories that I've seen about this phenomenon, about why that might be, and there's been some speculation actually that that young people today are basically able to substitute their seeking a high from substances with the seeking of stimulation through games, video games, and computer. So they're, addicted to the internet now as opposed to, other substances. So, but I think that, yes, we definitely need to be considering harm reduction as well. I mean, this is the message that parents are, getting out of the research, that you need to, definitely convey to your children that you strongly disapprove of using substances while they're young, because you want their brains to mature. However, if they, decide to use, that the parents will be there to pick them up from a party or whatever, no questions asked until the next day. That kind of message, and certainly from the perspective of clinicians, that is also the kind of messaging that would be important.
Okay. We have one more question that we'd be able to answer live. Do you see any correlation or known studies showing between vaping and marijuana use?
So do you mean vaping of marijuana, like the oil or the plant, versus vaping of nicotine? Is there a way to get vaping of nicotine? Got it. Yeah.
Yeah, perfect.
So I think there was a study that just got published that looked at what kids are vaping. So when they are saying that they're using an electronic vapor device, what are they reporting using in that product? And what I believe they found, if I recall correctly, was that there's a fair amount that are actually doing both, vaping e-cig, the nicotine liquid, and as well as the marijuana, the THC oils. So there's definitely a correlation between, the vaping. I'm not sure whether one has been shown to lead to the other. So if they start with e-cigs, they're more. Oh, actually, there is. I am recalling that there's a study that has actually recently published that's shown that the kids who start with e-cigs, just like either just flavoring or nicotine liquid, that they are more likely to develop marijuana use, alcohol use, tobacco use later. So I don't know if that's what you were looking for. I see another question. Great, yeah. Thanks. Are you finding marijuana is a gateway drug? Well, yes. If you mean by gateway drug, as in that's a substance that tends to be the first substance that young people start with. Because gateway drug could mean different things. Gateway drug could also mean, does starting with marijuana sort of increase the risk for addiction to other things? I think the jury is out regarding that, but for sure, with the greater kind of acceptability and the lower perceived risk of harm of marijuana use, and the greater access now, that marijuana is often the first substance that a young person encounters and starts with. Certainly today, marijuana is more a gateway drug than tobacco is.
Great. Okay, so if you guys have additional questions, feel free to reach out to Dr. Harris. Her email is listed on your screen right now. Now we have a few questions for our attendees. You should see the questions on your screen right now. You could answer these 4 questions for us. It would be greatly appreciated. And while everyone is filling out our questions, Dr. Harris, we do have additional questions that people want to ask you. I will compile them and send them to you in an email, and we will send these out to all of our attendees once I get a response from you.
Okay. Yes, happy to do that. And I apologize for the chiming. I wasn't paying attention to the chat, and so I didn't see the message about closing my Outlook. So my apologies.
Right, so we're going to give everyone about 45 more seconds to answer these questions that you see. All right, thank you guys so much. And I wanted to say thank you very much for everyone for attending the webinar today. And thank you again to Dr. Harris for this wonderful presentation. Thank you so much. And everyone have a great day.
Thank you so much. Thanks everyone for your attention.